Hello, my name is Ricardo Rio-Tinto. I work at Champalimau Foundation, Lisbon, and I am the first author of the study Magnet and Wire Remodeling for the Treatment of Candy Cane Syndrome, first case series of a new approach, recently published at Gastrointestinal Endoscopy. This study took place at Erasmus Hospital in Brussels, and the development of the Magos device was a collaboration between the Champalimau Foundation, the Erasmus Hospital, and the Brussels Medical Device Center. Let me tell you how this device came about. The group of Jacques Devier has had preliminary experience with the use of magnets for the treatment of esophageal diverticula, which was published in Gut back in 2015. These magnets were able to create an anastomosis between the bottom of the diverticulum and the lumen of the esophagus, but further cutting of the septum was technically demanding. The idea for a new device came to fix a wire between the two magnets to induce cutting by gravity. But one of our engineers, who was the grandson of a watchmaker, the idea of attaching a coil to one of the magnets in order to apply a continuous but moderate pressure and induce cutting through pressure necrosis. We call this process wire compression cutting. It works like a cutting seton used for the surgical management of anorectal fistula, but not requiring any manual adjustment. So, the Magos device consists of a flexible catheter preloaded with a magnetic device made of two individual magnets that are linked by a wire with a winding coil included in one of the magnets, which is activated at release. Each of the individual magnets is attached to the catheter and can be dropped independently. The Magos is designed to create compression anastomosis and wire compression cutting at one single step. The device achieves the entire cutting process in 2 to 4 weeks, and following the septotomy, the device is expected to spontaneously pass. In 2021, the Magos won the Innovation of the Year award of the European Society of Gastrointestinal Endoscopy. After initial design, the feasibility of the technique was tested on artificial septa in pigs. The animal studies showed that the Magos can realize a complete septotomy at various levels of the GI tract. A clinical trial was then started to assess the feasibility and safety of the technique. In two patients with symptomatic esophageal diverticula, the Magos worked to cut the septum with no adverse events. An article by François Oberlin describing the results in animal studies and in these two patients will be soon published in Endoscopy. We then decided to move on and to use the Magos to treat patients with candy cane syndrome. Candy cane syndrome is a rare post-gastrectomy complication after a creation of an end-to-side anastomosis to a jejunal loop. The excessive length of the blind loop resembles the so-called candy-shaped candy. Preferential passage of food to the blind loop induces early satiety, pain, and regurgitation. The technical complexity of revisional surgery and the fragility of the patient limit the possibilities for surgical treatment, and so a no-invasive approach for treating these patients would be desirable. 14 consecutive patients with candy cane syndrome were enrolled in the study. In all cases, the placement of the Magos was completed in a single endoscopy session in less than 15 minutes. 13 of the Magos systems migrated within 4 weeks after achieving complete septotomy. In one case, the device had to be collected from the right colon by endoscopy after 1 month. The septum was cut, the blind loop was then marsupialized in all cases, and patients clinically improved at 3 months follow-up concerning to dysphagia, pain, and reflux, and no procedure-related serious adverse events were observed. And finally, are there other applications for this technology? The impressive clinical results in esophageal diverticula and candy cane syndrome patients encourage us to continue to work on it. I believe that this concept of safe cutting of a septum could find many applications in remodeling the anatomy of GI tract for many other reasons or many other indications. The device should be available in multiple sizes and adapted shapes, smaller for the treatment of esophageal diverticula, including Zenker, why not, Larger to treat kinking of the residual stomach after sleeve gastrectomy or enteral stenosis associated with adhesions. Shape modified for stent-free creation of gastrojejunal anastomosis or for the enlargement of pre-existing anastomosis. I believe that this new device also brings a new concept with it, the concept of delayed results endotherapy. That will be a reality for many diseases in the future when complex microendoscopic devices will stay in place to perform specific surgical tasks in an effective and safe way. Thank you for your time.